Welcome to the Quality Podcast. This is your host, Arjun Venkatesh. I'm lead of the ACEP Emergency Quality Network, and we're exploring quality in emergency care. Today's episode comes from our stroke initiative, and we're talking about intracranial hemorrhage, we're talking about bundles of care, and we're talking about new guidelines. I'm joined by Corey Zackerson, who is co-lead of the Equal Stroke Initiative, as well as Josh Goldstein, who's director of Center of Neurological Emergencies at Mass General Hospital. I'm excited about today's conversation because it's work we've been doing for a couple of years. There's been a lot of new guidelines out, a lot of new research out, and so now is the perfect time to have this conversation and help spread the word. Josh, you're an expert in this space, and I got to tell you, ever since I was a resident, it feels like all the attention has been on ischemic stroke, and that ICH is sort of the stepchild. We have hospital quality improvement programs for ischemic stroke. We've got metrics for ischemic stroke. Our hospital gives out pins every time somebody gets TPA in under an hour for an ischemic stroke. ICH is a lot different, though. I think the teaching ever since I was a resident was there really wasn't much we could do. How's that changed? How's that make you feel as an expert in the space?
So first, I agree with your impression. Both sometimes the stroke team, everybody disappears once it's not like a TPA patient or an endovascular patient. And two, for ER docs, a lot of times in hospitals, if they need to be transferred, they're like, oh, click the transfer button and go on to the next patient, right? Or my job is to find a place to send them and then walk away. And so I think that is a true feeling, and I think it's really unfortunate. I think there's stuff we've known for a while is probably really good for our patients and really good doing it early and that everybody can do. And what's new is that we've now got a trial that shows us not only that doing these things is good, but we're now 95% sure that doing these things is good. So I think we're in a really great place now.
So I know there's a new trial that just came out. It's called Interact 3. It's really hard to keep all these acronyms on new trials straight. Tell us about this one, because from what I understand, it's probably the first real study that gives us some evidence to change how we take care of patients with ICH.
So here's what I would say on that front. First, I agree with you. A lot of people interpret it that way. And the real problem with ICH is we don't have a big randomized trial with a p-value of 0.05 that sort of drives therapy. Interact 3 was a randomized trial, was a cluster randomized trial of let's do 4 things together versus usual care. And that's what's really different. A lot of the prior randomized trials were let's do everything really, really well, except for we'll pick one specific parameter like blood pressure, and we'll target this number versus that number. This trial, Interact 3, was people should do whatever they're usually doing, which in a lot of cases is nihilism, which is, oh, if we're not 95% sure that something's good, let's do nothing, right? And let's say a bundle of care versus nothing, and see if it makes a difference. And that's when you really now see the difference. And so I think Interact 3 is the first positive trial in ICH, and this is probably the reason.
That's great. And I'd love to talk a little bit more about that trial, Josh. One of the things that I thought was really interesting about this study was where it was conducted, which was that it was primarily in low and middle income countries. And so I'd love to first start in just hearing your reflections on the setting and how you think those results then translate to the US context.
Sure. This has come up a few times with ICH, and especially like 2 of the biggest trials in ICH were Interact 2, which was almost positive, and then ATAC 2, which was not at all positive. One trial, the one that was almost positive, done mostly in sort of lower income places, and the one that was really not positive, done in higher income places. So some people looked at that and said, well, do it. There's a bunch of stuff that if you do it in low income places can make a big difference, but really our population is so different. I'll tell you, my interpretation was really very different, which was that in a lot of clinical trials, both groups, your intervention group and placebo group, get this really high level of attention and care. The placebo arm still gets a bunch of stuff that's really different than happens in the real world. And that happens a lot. And it only really gets highlighted when you do the trial in maybe lower income places where the control group really is just getting really control care. Interact 3, I think, really highlighted that the design of it was sort of cluster randomized trial, which is almost like let's introduce an intervention and see how it does compared to what they were doing anyway. which is different than the placebo arm of a big trial where they get super awesome care, but just not the one little thing we're looking at. And here's the real lesson. When you go to a place and say, let's do a bundle of super simple, easy things, do them well and clearly and be really ruthless about it, there's a benefit. And what I think is that we don't see that in the higher income places because we don't let our placebo groups get kind of like leave them alone in a way that so often happens in our usual care groups. And so really to me, the lesson to take home is doing stuff versus not doing stuff makes a big difference. Whereas the hard part is doing a bunch of great things except for one specific thing. That's much harder to tell the difference. So that would be my take home.
Yeah, that makes a lot of sense. And, we've seen this idea of bundled care before. Obviously, we've seen it with sepsis and early goal-directed therapy, and we all know how that went. And so I wonder if you can comment on how you think this might be similar to or different from early goal-directed therapy for sepsis. And do you see us heading down a similar trajectory with ICH?
Well, I think one of the big similarities with sepsis is, when the big Rivers trial first came out, it was super exciting. Oh, let's do this sort of bundle of care, which is really complicated. And then as people tried to tease it out and say, well, let's do best available care except for this one thing, now all of a sudden a lot of that benefit goes away. And I think what you see with the original trial was it was early goal-directed therapy against really very loose, non-targeted therapy, a lot more like nihilism. And so the benefit is much bigger in that case. And maybe what we've learned is it's not so important what each specific parameter is and whether you target some specific number or not. Having a target and trying really hard to hit it is a big benefit. The specific target may be less so. And I think that's what we're seeing here with Interact 3. Is your goal blood pressure this number versus that number? And I think what you're really seeing is when the clinical trial is, let's be ruthless about blood pressure in both arms, but just have this target versus that target, hard to detect the difference. But now let's just roll in and say, hey, do whatever you're doing versus let's pick a target and actually be ruthless about it. Now you see a big difference. So maybe the actual target is less important than just being committed to picking a target for blood pressure and a target for glucose and a target for anticoagulation reversal and a target to do it early. And then that's when you really show a difference.
Yes, that's a good point. And I think, the quality improvement world, there's a ton of literature and people always get caught in these little debates around every time there's a bundle, which is which element mattered the most. And when you really step back and you look at a lot of these things, what you find is that's usually just a pretty academic question. It doesn't really matter which thing mattered the most. And some people, and Don Berwick himself would say that these things only work because you do all of them, because it puts attention on the topic. And if you pull every lever down at the same time, you're actually going to have a big impact. And it feels like that's sort of the case here with ICH. It's that it's sort of working on all these different things at the same time. Each of these elements has to be done, and it sort of matters less which one is more important. Is that just my feeling, or does that bear out in the science as well?
Well, here's what I would say. If we look at just the Interact 3 trial itself, which was a bundle of care, it's blood pressure control, glucose control, temperature control, and anticoagulation reversal. There's those four things. Most of the benefit was driven by blood pressure control and by what looked on paper like a relatively small difference in what actually happened with the blood pressures in the patients. And so the narrow look would be that. The bigger picture look in my mind is, why was this trial successful when so many others weren't? And I argue that it is exactly what Dr. Berwick was saying, was that doing the treatment in isolation doesn't really give the full benefit. It has to be, you're giving people the full package. And that, as you said, it forces people to pay attention. It forces people to optimize everything. I need to control your blood pressure and your glucose and your temperature and reverse your anticoagulation. And I have to do all these things early. Then the benefit really has an opportunity to show up for people.
That makes a lot of sense. In looking at the results, it did look like a lot of it was driven by blood pressure. But one of the other things that I noticed with the group of patients on anticoagulation was actually quite small. I think it was about 1% in both groups. And so that is both different from the US context and maybe something to reflect on, but also I wonder how you think about interpreting the role of anticoagulation reversal in this bundle, given that that was such a small group of patients in the study.
Sure. I'll first point out, totally agree. This is unlike the US population, where up to 15 or 20% of our ICH patients are anticoagulated, and a lot of them with DOACs. In this group, in the INTERACT-3 trial, mostly in lower income countries, much fewer people were anticoagulated, and a lot more of them were on warfarin than might be found, for example, in the US population. So I think that the one piece is I agree within the context of the INTERACT-3 trial, very few patients needed anticoagulation reversal, so they didn't have a chance to impact the outcome. But there's so many other trials that are suggestive, I'm going to say suggestive, that reversing anticoagulation changes outcome. And I'll also put that if it's ever going to help you, early is the time, right? If you're reversing anticoagulation, you're trying to prevent more bleeding in the brain, hematoma expansion. Most of that action is early in the first hours. If you're ever going to help that patient, giving that in the first hours is when that time is going to help. And there's plenty of suggestive evidence that if we do that, it decreases bleeding in the brain. Suggestive evidence that less blood in brain is good for you and more blood in brain is bad for you. So I would argue that in the context of the other data we have, it really argues that anticoagulation reversal is a key part of it. I'll even put there's one group in Germany did a nice retrospective study of looking at blood pressure control and anticoagulation reversal, and found almost that if anybody's going to benefit, it's those who got both. It's both blood pressure lowering and anticoagulation reversal together to really have the impact we wanted on the patients.
I need to put a little bit of a reality check in here, which is that, we're talking about a disease that's pretty rare. And I think one of the things that's hardest for ER docs, and particularly for EDs that are trying to do quality improvement, is that we feel like we're trying to do quality improvement on 100 different topics. I think I asked my nursing director recently how many different QI projects we have going, and the answer was 47 in the ED right now. And we know that when we work on that many things at one time, it just turns into noise, but we're in the fishbowl in the ED. And so sort of one of my concerns and one of my challenges I think about when we think about quality improvement for ICH is, how do you do it in a way where we can put attention on this one topic, we can build a QI package around it, we can implement programs locally, but in a way that it's realistically lives alongside all those other demands and all those other things that we're being sort of asked to do. And sort of how should ED leaders think about that?
Well, I think the first thing we got to think about is, especially for uncommon diseases like ICH, we got to make it as easy as possible for our docs and our nurses. And how do we sort of dummy proof it? I think one of the things that we've done that has been a challenge is, for example, for ICH, that there's a big set of guidelines that gets written every so often. I'm one of the co-authors on it. It's like 100 pages, right, with dozens of things that recommends, many of which are, well, it might be reasonable to do X, Y, or Z. Probably what we really need is that when a patient with ICH is diagnosed, there's like a one-page, just do these things, or an order set that says, our hospital has decided these are the things we're going to do, and we're going to set a blood pressure target and a time to reversal target and a goal glucose target. And it may be different than what some other hospital has chosen. And it may be, maybe we're, instead of being 95% sure that these are the right numbers, we're only 90% sure or 85% sure these are the right numbers. Fine, right? And you pick them and you do them, and the frontline providers know that, oh, this patient has that thing, let me look it up or click on the button, boom, do those things. And I think that's the way to go. I'll add, I think, for your 42 QI projects or whatever they are, and I'm sure my hospital has a similar number going, is this particular disease is a catastrophe. It's one of the most deadly and possibly the most disabling disease our patients are going to have. And I do think that it's reasonable to say, let's focus really hard on these super high acuity, high disability producing events.
One of the things as we talk about sort of having this sort of set of things that pops up that we're all ready to do is, maybe we are only 80% sure of what the right number is, but we still need to pick that number. And so, we've seen the AHA guidelines that you're a co-author on. We've seen actually the, proposed ICH metrics that our eQual group came out with, and we have all these different numbers floating around. And so if we're looking at improving our process here in RED today, can you give some guidance on what is the number that you would choose for blood pressure, and how do we actually just make that happen?
Fantastic. It's a tough question. Here's what I'd say. So the INTERACT-3 trial, which is arguably our first big positive trial in ICH, their target was systolic blood pressure less than 140 and target that within 1 hour of arrival. Now, I will say this is a population of patients that, as I said, disproportionately lower income, disproportionately hypertensive, maybe not reflective of the US population as much. And even more so, when you look at the trial, most of their patients didn't hit that target of less than 140 within 1 hour. A lot of them took many hours to get to less than 140. And yet they still got this benefit. So I would argue you can make a pretty strong case. The benefit comes from the attempt to hit this aspirational target, even if you don't actually hit it. So what I might put is that the QI project is pick a target that for your hospital. And it's okay if that target is different than some other hospital, but your hospital should have a target and a goal of hitting that within, starting treatment within 1 hour, maybe hitting that within another hour. Maybe that's achievable. Maybe the next goal is hitting whatever that target is within 1 hour. Less than 140 is reasonable. The risk is that you can shoot too low. There's some evidence that going less than 130, 120, or having these big fluctuations in blood pressure over short periods of time, that can be harmful. I think if you were to pick aiming for between 130 and 150, a systolic between 130 and 150 gives you enough range to work with, gives you and your nurses enough of a range where you're not going to overshoot, you're not going to undershoot. It's an achievable goal. And saying, boy, getting within 130 to 150 within 1 hour would be fantastic and a dramatic improvement over what commonly happens in a lot of places.
Great, thanks. And as we continue to think about this sort of bundle that we're implementing in our hospital, I'd also love your thoughts on imaging, and should we be including CTA in our imaging? And maybe we can think about that both in the context of the place that has CTA there and it's easy, and then also in the context of the place that might have to push and make some arguments to the hospital to try to get CTA, and how forceful of an argument should be made there.
Sure. So I would say first, Corey, as you may know, CTA is near and dear to my heart. I would feel great if all ICH patients underwent CTA. The risk in this population is minuscule. There's a catastrophic disease, and finding that AV malformation or that aneurysm underlying this ICH is going to make a dramatic difference in how this patient is managed. And you can also find markers of hematoma expansion. If contrast leaks into the hematoma, those are the people who are going to have more bleeding and get worse and need much closer neurologic monitoring and are at higher risk. So I think you can make that case. Now, so if you're at a hospital that it's easy, I would probably advocate that everybody should get a CTA. If you are at a hospital where it's really difficult, then you should pick the highest yield folks. Those are going to be mostly the youngest patients, at least in the US, the older folks with ICH, mostly low. The older folks with ICH, mostly you're going to have a hypertensive bleed or from cerebral amyloid angiopathy. Your CTA isn't going to show sort of a large vessel malformation, but the younger folks will. And again, this would be a good opportunity for your hospital to have in its bundle that given our use of CTA at our hospital, these are the patients with ICH who should get a CTA, and pick some reasonable range. There's a lot of different ways to slice that particular approach, and any of them are reasonable. But that way, the poor frontline person at 3 a.m. isn't trying to think to themselves, boy, I wonder if I should get a CTA. They've just clicked the go button. Here's our code ICH protocol, and go. And it's all built in.
So Josh, I've heard you talk about code ICH almost like it's its whole process and alert. In our shop, we've got a STEMI code where I can basically walk over to the unit secretary and say, hey, that's a STEMI code, overhead goes out, cath lab gets automatically activated, and the whole machine takes off. Same thing. We have a stroke code we use broadly, but often that's not the best way to identify a lot of ICH patients who may just come in altered or with a headache. And, they don't always, what we find with our ICH codes is they don't fall in the same place. We did a QI project a couple of years ago and created a separate ICH code that goes on as an overhead. Do you think that's the way this needs to go? Like that this has its whole separate alert process when you say code ICH? Or is that more of like just having a protocol on a piece of paper?
Wow, this is really interesting because it gets into what's our normal workflow. And I think a lot of times, like the code stroke is somebody with stroke symptoms. We don't yet know it's a stroke, right? And we launch the code stroke. The whole team comes in and does it. Same with like the code STEMI. The code STEMI we might activate because we've seen an EKG, right? That shows, we've got the diagnosis. So I would put the code ICH into the category of, as soon as you've diagnosed that ICH, it launches your code ICH. And that may be overhead, or it may be on pages or pagers or whatever. It could even be that the future is this clever AI algorithm in this scanner, right? Whenever the scanner shows an ICH, boom, it sends it out, right? That's the first you hear about it, before the radiologist has even seen the image. And so in my mind, what it launches is like, oh, now there's a bundle of care. Now I have to rush to reverse their anticoagulation. And if I'm giving them PCC for their warfarin reversal, I'm then rechecking the INR right afterwards. It's a lot of times we sort of go on this, give something and then walk away to the next patient. And what I'd like this bundle to be is sort of force everybody to think, oh, I do the thing. Oh, is it done yet? No. Have we titrated the blood pressure medicine? 15 minutes later, go back and check. Oh, we're not there yet. Keep it going. So I would love it to launch this sort of bundle of care, whereas maybe we don't have with STEMI, where the patient gets whisked off to the cath lab and then somebody else just takes care of them, right? Here, these patients are going to be, I think, in our emergency rooms for a little while, no matter where you're at. And so we have to be working on them.
Yeah, and I think that's a great point. And there's real good papers out there as well that show that when these patients board in the ED, mortality is higher. And so this is, I think, really interesting that we now have some evidence in science that says what we do matters, and that we can sort of reduce some of that harm. One of the hardest things with this patient population is there's a lot of cooks in the kitchen. And so at our shop, historically, the neurologist had one view on blood pressure. The neurosurgeons had a different view on blood pressure. If you're at a place where there's no neurological ICU, you might have some medical intensivists that have another view on what we're doing. How do we get to like some degree of agreement? And do we even need it? Like, are we sort of putting our hands up because we're so afraid of the disagreements that we're not sort of acting the way we should? But how do you navigate that?
Yeah, I'd say the first thing to do is to recognize that a lot of times when there's a bunch of cooks in the kitchen, we do nothing until somebody has made a decision. That's got to be our enemy, right? And what I would argue is us in the ER should make the decision first. And the admitting person can change it later, right? Maybe that intensivist will say, oh, actually, I want this other blood pressure. Fine. But the enemy is, I'm going to do nothing until that guy makes that decision. And I think that's what we want to move to is the default is a clear package of things, not a default of let's do nothing until somebody decides. I'll add, as far as the neurosurgeon thing, another super exciting trial, Enrich, was announced. The paper hasn't been published yet, but the first surgical trial in intracerebral hemorrhage has come out positive, arguing for we now know which patients are going to really benefit from surgical therapy. We're all waiting for the paper to come out. When it comes out, I hope we do another podcast. But my hope is that will teach us all, these are the patients the neurosurgeons should be taking care of because they're going to do a surgical treatment. And here's the non-surgical patients that we should be letting the neurologist drive the bus, for example, or the intensivists.
No, I love that. We'll definitely do a podcast on that when it comes out, because I think too often than not, the emergency physician gets frustrated when they've got a case, they see the hemorrhage, and you're sort of left in limbo waiting for the neurosurgeon to say that's operative or that's not operative. It feels like it's really gray, highly variable. The criteria are always very unclear. And so it's frustrating. And you're right. We probably, don't take care of a lot of things we could do with medical therapy in that window. But we're confident we do it everywhere else. We think of every septic patient we admit to the hospital. We have no doubt about giving them antibiotics broadly, and then knowing that the team will change those antibiotics later. And I think that sort of same mindset, knowing that we're the ones at the bedside, we're the ones in front of the patient, and that we can act and we have something that can make a difference. We got to take advantage of that.
Totally agree with you.
Yeah.
We should act early, and it's totally okay that with time and with multiple consultants, some different decision will be made later down the road. That's fine.
That's the last question I want to ask you about, which is time here. Our specialty in emergency medicine, we initially got created sort of being, I would often say, the Band-Aid to the healthcare system, which was other people didn't want to work at night or on the weekends. And we started creating ER docs and staffing emergency departments. But it's the last 10, 20 years of research that really shows the heart of our specialty, which is that minutes matter for certain illnesses, that there's really acute illness and injury out there. And the best examples are acute coronary syndromes, stroke, trauma, cardiac arrest, sepsis, where we have trials and data that shows that if an emergency physician does something in the order of minutes or early intervention, it makes a difference versus, say, waiting for a day or two and otherwise just letting the specialist do it upstairs. Tell me a little bit about this data in ICH. Like, it sounds like now we've got some real data that says that if we do it early, and when I say early, meaning in the course of someone's average ED stay, it's going to change the outcome.
Sure. So first, I agree with you on all the fronts you said, and there's definitely some diseases that it really makes a difference whether you do the thing in the first hour or not. I would say for ICH, that level of evidence has been building. And it's still building, and I think the INTERACT-3 trial adds to it. Now, the interesting thing for the INTERACT-3 trial, the blood pressure intervention was do this over 7 days, right? It was 7 days of blood pressure control, but one of the goals is to aim for less than 140 within the first hour, which was a key piece that hadn't been put in the prior randomized trials of blood pressure control, where people were enrolled and had a sort of a target aim for this blood pressure, but it wasn't like aim for it within the first hour. So this trial, people had their blood pressure lowered fast, and there's a good chance that made a big piece of the difference. I'll say why. It's because a lot of the things we worry about is hematoma expansion, more bleeding in the brain. Much of that happens early, and so if you're waiting for 4 hours, 5 hours, 6 hours to go by, maybe you say, "Oh, I'm going to wait till we transfer the patient and let the receiving hospital go do the thing." Well, this magic time window may be lost by then. And so I think that it's very suggestive evidence that this time window really matters. It's the same, I think, for anticoagulation reversal, that all of the benefit of it probably comes if you give it before the patient has expansion, but all the cost is the same whenever you give it to the patient, and all the adverse events are the same whenever you give it to the patient. So you give the same treatment later, they're getting all the cost and the harms with less benefit, right? And if you give it early up front, you're optimizing the benefit for that same harm and cost profile.
It's interesting. I often call that the rescue paradox in emergency medicine, which is that there are many of these acute illnesses where early intervention prevents the more severe form of the disease. And so it gets really hard to do quality improvement. Sepsis is a good example where you have a patient that's kind of got, sepsis, lactated 2.5. You give them early antibiotics and some resuscitation, they never end up in shock. They never end up in the ICU. They never end up in our quality metrics. And I think the same often is true in acute cerebrovascular disease too, where if you get that patient that is earlier in their phase of a stroke or an ICH and we intervene, we never see potentially some of the more severe or catastrophic versions of that illness. And we're caught being like, well, it's not a very common disease, or, oh, that wasn't a very bad case, but that's because we rescued the patient. And so I think finding a way for us to see that and show that is going to be really important to showing the importance of emergency medicine.
Totally agree. That patient with a really, really small hemorrhage that you did get a very expensive treatment on and made it not be a big hemorrhage, you changed their life in a huge way. But then afterwards, everybody says, "Oh, it's a small hemorrhage," Well, yes, and we kept it that way. And we didn't make them like this horrible catastrophe, right? There was this profound lifetime disability. We prevented all that.
Thank you both. That was an awesome discussion today on quality. I learned so much, not just about sort of ICH broadly, but also some real tactical tips there around how we can implement this locally within our EDs. I always give every one of our guests the chance to have the final word. And so this is your soapbox to all of the equal participants out there that are doing stroke QI projects. one thing that you want them to walk away from this knowing, or the one thing that you wish every ED in America could do. And I'll let you both take a go at it. So Josh first.
Fantastic. I would say that the key thing is nihilism is your enemy. Don't do it. If you're faced with an ICH patient, you think, I just got to get this patient to a neurosurgeon and otherwise there's nothing to do. No, there's tons of stuff you can do in a community hospital that will have a big benefit for this patient. And don't think to yourself, those are just simple things. They're not a big deal. The simple things are a big deal. You are changing this patient's life, and you should be doing it every time. You have the power and you should do it.
Yeah. And just to sort of build on that, I think, Arjun, you raised the question earlier about having all of these different QI processes and all of these different things that we're trying to do. And are we just, fatiguing ourselves with, shining a flashlight here and a flashlight there? And should we just, instead be kind of thinking more globally about quality improvement processes? And I think that that's fair. And I think, I understand the exhaustion, but just to underscore what Josh is saying, this is a condition with really high morbidity and mortality. And it's really exciting that we're starting to see evidence that there is something that we can do in the emergency department and that, we really can impact these patient outcomes. And so just to push back against that sort of QI project fatigue and to recognize that this is a place where we can really make a difference.
Josh and Corey, I want to thank you for an awesome discussion today. I learned a lot. I think I'm walking away from today recognizing that first, ICH is a very treatable illness, and what we do in the ED actually matters. This is not the death sentence that I learned it was during residency. I'm learning that the interventions are pretty focused and important. We got to get the blood pressure down. We got to reverse the anticoagulants, and we got to get people to destination centers for definitive treatment. And then finally, and probably most importantly, what I'm recognizing is that this is another place where bundles of care really matter. It's about doing quality improvement as a team with our nursing colleagues, across services with our neurology and neurosurgery colleagues, and really building a bundle that we can deliver together just like we do for ischemic stroke, making sure we take those learnings to ICH. So thank you both. This was a wonderful episode. Look forward to having you both on in the future.